Thank you again, and thank you, Dr. Reddy. So I'm supposed to talk in 15 minutes about practicing changes, innovations in pediatric brain tumors, and I thought, what's the best way to do it at this end of the hour when everybody is tired? So I think I'm going to touch on 4 or 5 important tumors, and just a brief on the newer therapies which we are doing or what we propose to do in the next few years. So this is epidemiology of brain tumors. We see gliomas are most common. This is a very standard slide. Now, this is a very cumbersome slide, but what I wanted to show you is that over the last 10 years or so, we have had treated a lot of tumors in different ways, like the diffuse intrinsic pontine glioma. We have treated by temozolomide radiation. The Germans have treated in a different way with more intensive therapy. We have talked about low-grade gliomas. I heard Dr. Jalali speaking about it. I touched upon the epidemiology, how they are being treated currently in US. And medulloblastoma, we heard a very nice talk by one of our previous speakers, talked about different ways they are being treated currently, both in US or in Europe. We have treating high-grade gliomas by radiation and chemotherapy. The Germans treat it also intensely, and we have different ways to treat it. But this is what we have been doing. So the question is, what is next? So CNS tumors, unlike other tumors, are the most difficult to treat. Therapeutic challenge continues. Death from brain tumors in children are the most important cause of mortality. So the future is the need for innovative therapies. So advancement in therapy of pediatric brain tumors, just a minute. Surgical intervention, we heard excellent talks. We do these functional MRIs, the mapping more in adults with GBMs. We specialize in local regional delivery techniques. We do intraventricular approach of chemotherapy and biological agents. We have the convection-enhanced delivery into the brain. Neuroradiology, we talked about all these excellent things which have been doing to enhance our understanding and diagnosis. We do diffuse tensor imaging and fiber-tactography in diffuse pontine gliomas pre- and post-treatment. Radiotherapy, I'm not going to talk about, we had a lot of that. We do proton therapy, scanning beam proton therapies, etc. But what is most fascinating is really the answer is to dig into the molecular profile of different tumors, understanding the genomic landscape and the epigenetic machinery. So medulloblastoma, we heard excellent talk previously. So I'm just going to very briefly, for the WNT we need reduction in therapy. It has been stated. For the sonic hedge we do this. And for the group C and group D, we really don't know what to do. So in 2013, we met in Australia and identified the WNT group as low, average, and high risk, and we have the non-WNT pathway or the non-sonic hedge. So right now, when a child walks in with a medulloblastoma, we send it for the WNT classification or the sonic hedge or the non-WNT, non-sonic hedge. That's the group 3 and group 4. So that's where we start. So we talked about sonic hedge, a previous speaker told good things about it. But when we treat it with sonic hedge inhibitors, immediately there is resistance. So we have to understand the molecular mechanism of resistance, and that is only when we can profile innovative therapies. Otherwise, we'll be back against the wall. So mechanism of resistance, these smooth inhibitors, we have acquired mutations, we know that. The downstream, like the GLI, the MECAN, the cyclin D, we know about that, how they can overexpress and undermine our therapeutic efficacy. We have upregulation of these important molecular markers. We have the upregulation of P-glycoprotein substrate, which is a multi-drug resistant marker. And also the truncated version of the GLI is really baffling, and that enhances our resistance to this. So how can we overcome? We now know the mechanisms of resistance. So one is we have to find smooth inhibitors that can bind and inhibit the smooth wild type. We have an active aid, which is a small molecule, which is used to get neuroblastoma, and that binds against the human form of smooth, the SMO actually. Now, the other thing is how can we target the GLI? On the preclinical model, the GNT5, 8, and 6-1 have been used in neuroblastomas. We have to target and use them to exploit and make our therapeutic efficacy. Arsenic trioxide is a very standard drug which we have been used, but it's interesting. It blocks the sonic hedge migration of the ciliary into the nucleus. Number C is inhibition of the PI3K. We all know the PI3K is an important signaling pathway. So you use this. Visomedegib has been used, but it doesn't really work. It just excites sometime, but then the tumor comes back with vengeance. So we have to use this with a PIK3 inhibitor. It has been shown in mouse models to decrease the medulloblastoma growth. Similarly, we use a dual PI3K inhibitor that will help us. We have to use this along with the standard sonidegib, which is LD225. Itraconazole is a standard antifungal which we have used. Combining them with arsenic trioxide decreases the ciliary localization of the smooth signaling pathways. So we understand the resistant mechanisms. It's time now, over the next few years, we have to design trials and take this so that we can overcome all this. And that's only where we're going to make progress and innovation. Now we talked about the Wnt. We have to decrease and de-escalate therapy. We already heard from our previous speaker. But there is a subclassification of Wnt, which is the PARP inhibitors. And we have known that this is a bad type, 10% of Wnt-driven pathways. So we use Wnt pathway inhibitors is to target the PARP inhibitors. So using PARP inhibitors will help to overcome the resistance of the 10% of the seemingly good Wnt-driven tumors. We have used VEGF. We know that we have a trial which we use Avastin with thalidomide, saloxib, fenofibrate with intraventricular infusions of etoposide and Aracy. It has good outcome. It's been published, and we are treating at least 2 patients right now on this. We are using the Notch inhibitor. The Notch inhibitor trial has been closed in recurrent CNS malignancies, and Notch is important and a pathway, especially in the sonic hedge type. Going to the group 3, we talked about group 3 is really very difficult to treat, so we are using vorinostat, but we are using also how we can target the MYC modulator, and we are using as a hypermethylated tumor, we are using hypomethylating agent, just like I talked to you about in my previous talks. Group 4 is equally bad. Its outcome is better, but it's very elusive because we cannot make ideal mouse models. So this is another baffling tumor, a subtype of medullos, but it's hypermethylated. We need to use a hypomethylating agent. So we know what's medulloblastoma. We know the 4 molecular subtypes, but what we need to know and identify is why it causes resistance. Now we know that. So the next 5 years, we have to really put our effort into identifying trials, how we can overcome that. That's where innovation will come and therapeutic efficacy will be defined. We go into pediatric low-grade gliomas. Dr. Jalali present, very good. I'm not going to go over details, but the last few years and the future, what is it? Dramatic evolution of novel technologies, plethora of molecular data has evolved, improved understanding of the deregulated pathways. A lot have we learned from neurofibromatosis and tuberous sclerosis models. So profiling of molecular targeted therapies, is it going to complement or provide preferment over the conventional treatment? So this is all of a BRAF fusion. It's very interesting. We have a BRAF fusion and we have BRAF mutation. So mutation is very simple. We throw in a drug and the child probably gets cured. But what happens to a fusion? So in the fusion, we have to use a downstream target like the MEK inhibitors. We'll discuss that in the next slide. So understanding frustrations of treating this is very important. So pilocytic, pielomyxoid, gangliogliomas, they have high level of fusion. So fusions can be now treated with downstream MEK inhibitors. It seems to work in certain cases. So this is a publication we did where we are seeing this pathway. We are using vemurafenib, dabrafenib, different drugs. Most important, selumetinib, which is a MEK inhibitor 1-2. We go onto this pathway, the PI3K, AKT, and mTOR. I'm going to spend half a minute on a very interesting. We had a child who had a pleomorphic xanthoastrocytoma. The surgeon went in and then gave up. And he said, I cannot because the artery is going through that. And we found it was a BRAF. The St. Jude's published BRAF. They threw in the drug, they was excited, they published, but it came back. So it's no use. So now we have a trial at MD Anderson. We're going to block this pathway with this pathway, that is vemurafenib with mTOR. This child is now 26 months on trial and is wonderful, doing well. We are presenting this at the ASFL. So multi-targeted therapy is really the answer. So again, the BRAF MEK inhibitors, the current status, not going into the details, we have various trials which are going. A simple, interesting thing for the scientists. Selumetinib is a MEK1 inhibitor. In mouse models and in cell lines, it didn't show any efficacy. It had poor CNS penetration into the mouse models. But when we did it in pediatrics, it had a 38% response. Sometimes we don't understand because the CNS blood-brain barrier is so elusive, especially when a tumor is there. So the final slide on the low-grade gliomas is the crosstalk. We have to understand both the pathways better, and then only we can have efficacy using mTOR with BRAF inhibitors, use everolimus, which is an mTOR which has been already done. It has some efficacy. We have used this, as we talked about, rapamycin we have used, selumetinib efficacy has done. But now we have understood the STAT3 activation undermines its efficacy. So we're designing a trial using selumetinib with a STAT inhibitor. So understanding these things and defining trials will really provide the innovation, though it's going to be challenging. So targeted therapy in pediatric gliomas, low-grade gliomas, I'm going to skip this, but remember, Avastin and irinotecan does help in pediatric low-grade gliomas. We have treated this, and there was a paper published a couple of years back. Immunomodulation, so it's very interesting. You've all used lenalidomide, which is an immunomodulator. It's an anti-angiogenic. It's a direct cytotoxicity. A COG phase 1 study has been completed with tolerable toxicity. Now the phase 2 study is ongoing. I will skip this for time, but this is very important. Immunomodulation is another interesting thing in pediatric low-grade gliomas. So the future of pediatric low-grade gliomas, understanding the crosstalks, profiling optimal therapy against these targets, and biology of rare variants, and to see, hopefully in the future, if these biologically driven trials can supersede or replace the conventional therapies. Switching gears to pediatric high-grade gliomas, a couple of minutes on that. We know about high-grade gliomas. It has a poor survival even in adults and pediatrics. Secondary GMF is very rare in pediatrics. So looking at the very interesting paper, there is a lot of molecular characteristics. It's a lot, but I'm going to go very quickly over that. We know the histone modification, especially the H3F3A. This has been identified now, and we can target them. And we see this in about 15 to 20% of pediatric high-grade gliomas. You know the ALT telomere is lengthening, as I talked in my previous talk. We really need to design a trial targeting this telomerase inhibitor. The one which we did was too toxic. Mutations of this H33ATRXDXX, which is the programming death cycle, which along with T53 mutation causes a significant genomic instability. So we need to understand that, and it's about 30%. What is very interesting, children less than 3 years who do not have who have less incidence of P53 mutation do well. So lower rates of P53 mutation are in children less than 3 years. PDGFRA, we all know, we target them, seen in 30% of DIPGs, we have a multi-targeted therapy. BRAF mutation we talked about, we have a 15 to 20% in pediatric high-grade gliomas, and we can treat it with dabrafenib. There is an ongoing trial. I'm going to skip this, but this is interesting. NTRK fusion is a neurotropin receptor family. There is seen in about 40% of non-brainstem tumors. So the question is whether we can define a therapy against it or a trial against it. So pediatric high-grade gliomas across the board are now classified into 6 groups. You can see the histone methylation. You have the RTK inhibitors like the PDGFR, which I talked about. So now with the extensive DNA methylation, with the whole genome sequencing, digging into the epigenetic machinery, we can have now identified 6 subtypes of pediatric high-grade gliomas. Immunotherapy in pediatric high-grade gliomas, I've talked about in my previous slide of vaccination with these glioma-associated antigens. Dendritic cell vaccine was done from actually UCLA by Joe Lasky group. What we are now proposing to do is intratumoral administration of natural killer cells, because natural killer cells work well in gliomas. So we're going to do that directly into the tumor. In the next year, we hope to open it. And again, we talked about a lot of nivolumab, which is a PD-1 inhibitor. It's very interesting. In a small subgroup of patients with hypermutant GBM, which is biallelic germline mismatch repair, seen mostly in Arabic countries. Actually, sick children Toronto opened the nivolumab with this. Finally, we're going to go into the hypermethylated pediatric brain tumors we talked about in our previous slide. All of these are hypermethylated, so we need to use a double-sode approach, treating them with decitabine and vorinostat in pediatric brain tumors. That should be the future. And finally, the last one is ATRT. ATRT is a simple drug, simple tumor, but now with the understanding there are 3 subtypes of, not going into the details of time, but this is very exciting. We just can't throw in therapies, chemotherapies. So I don't know how much, what could I do? So ATRT remains a very significant tumor, but you understand the molecular pathways, intraventricular infusion of NK cells, and use of hypermethylating agents. Difficult to summarize in 15 minutes. So understanding the genomic and epigenetic profile of these tumors are important, and most important is being able to comprehensive evaluation of all these data and define the best innovative therapy for the future. Thank you.